Everyone, to our bi-monthly spinal cord injury in services. This month, Dr. Neil Patel is going to be discussing neurogenic bowel and bowel programs in individuals with spinal cord injury. Thank you, Neil. Take it away.
All right, sounds good. So I'm Neil. I'm one of the PM&R residents here on my SCI rotation, working with Dr. Abramoff. I'm going to briefly discuss neurogenic bowel and bowel programs in spinal cord injury. And so to start off, I want to talk briefly about normal bowel function. And so this is defined as passage of regular soft form stool. And you should have sensation in the rectum, along with ability to control when to have a bowel movement. And I have normal in quotes because normal can kind of vary from person to person. It can range anywhere from 3 bowel movements per day to 3 per week, and that all can be normal, just depending on the individual person. And below I have the Bristol stool chart, which many of you have probably seen, and it kind of just classifies stool based on consistency. And in the middle, like type 3 and 4, that's what's classified as a normal stool. And then on the top of the list is stool that you might see with constipation. So it can be like hard, you might have small lumps. And then as you progress down, it becomes looser, and then all the way down at the bottom, type 7 is liquid consistency. And this would correlate with having diarrhea. And then briefly, just the rectal anatomy. I have a diagram here on the right-hand side, just showcasing the internal and external anal sphincter. And I want to highlight the internal anal sphincter is controlled by smooth muscle, which is involuntary. And then the external anal sphincter is skeletal muscle, which is under voluntary control. And I also want to talk about 2 reflexes. And so these are natural reflexes that we have to help facilitate having a bowel movement. And the first one is rectocolic, and this is a physiological reflex where stretching of the rectal wall helps to relax the sphincter and initiate a bowel movement. And then the other one is gastrocolic, and this is a physiological reflex that controls the motility of the lower GI tract following a meal. And so the colon has increased motility in response to the stretch of the stomach after a meal. And, looking back, many of you may have experienced this yourselves, where you have a meal and then you might have the urge to have a bowel movement shortly after. So that's a result of this reflex. And then the enteric nervous system. So this is a nervous system in the gut that plays a role in movement of stool through the colon. And it's important to know it can function independently from the central nervous system, but it is influenced by the autonomic nervous system. And then I want to highlight 2 of the plexus that are involved. So the myenteric or Auerbach's plexus, this plays a role in the musculature of the gut, and it's involved in contraction and peristalsis. And then there's the submucosal or Meissner's plexus, and this is involved with glandular secretion and then also chemical monitoring. Going into neurogenic bowel, so this is defined as the loss of normal bowel function, and it's caused by a nerve injury. And for our discussion, we're mostly focusing on spinal cord injury, which is certainly a cause of neurogenic bowel, but it can also be caused by other neurological problems like ALS, MS, and stroke. And it results when the signals between the brain and the colon are disrupted, leading to bowel dysfunction. And 2 main categories of neurogenic bowel are like a spastic or reflexive bowel, and this is when you're unable to voluntarily relax the anal sphincter, and this leads to constipation. You can have accidents when the pressure of the stool buildup kind of overcomes the anal sphincter. And then you can also have a flaccid bowel, and this is where you have decreased peristalsis, decreased movement in the colon, a flaccid sphincter, or a relaxed sphincter, and this can result in constipation and then also frequent leaking of stool. And some bowel problems after SCI. So it's very common in patients with spinal cord injuries. It can occur in 27% to 62% of patients with spinal cord injuries. And common problems include constipation, distension, abdominal pain, rectal bleeding, hemorrhoids, bowel accidents, I think is a big one, and then autonomic hyperreflexia. And having a spinal cord injury, it causes slow transit time through the GI tract compared to someone with a normal bowel. And then it can lead to no or decreased sensation in the rectum. And then I think importantly, it has a big impact on patients' social activities and their overall quality of life. So the goal of the bowel program is to have a bowel movement at a scheduled time and to be on a routine. And the ultimate goal is to prevent accidents and maintain continence of the bowel and minimize complications and then GI symptoms that might be associated with neurogenic bowel. And overall, I think one of the biggest goals is to improve a patient's quality of life. And then I briefly want to talk about upper versus lower motor neuron lesions. So the upper motor neuron lesions is any injury from the brain or the cortex to the corticospinal tract in the spinal cord. And then a lower motor neuron lesion is any injury from the anterior horn of the spinal cord, as shown in the picture on the left, to the peripheral nerve, muscle, or neuromuscular junction. And both lesions can present differently. So on the left, I have an upper motor neuron lesion, and this can lead to spasticity, hypertonia, hyperreflexia, a positive Babinski or upgoing toes on plantar stimulation, clonus, and then this one is less associated with muscle wasting or atrophy. And then a lower motor neuron lesion can lead to flaccidity, hypotonia, hyperreflexia or diminished or absent tendon reflexes, no clonus, and then this one's more likely to be associated with muscle wasting or atrophy. And I differentiate these two because their bowel programs are different, and that makes sense because the problem is different. And so for an upper motor neuron bowel program, the problem is spasticity or tight sphincter. And so for this, you can use stool softeners. We often use Colace here, and then Senna, and then a bisacoidal suppository with digital stimulation. And the goal is to ultimately have a soft formed stool after digital stimulation. And then a lower motor neuron bowel program, here the problem is flaccidity and a loose sphincter. And so here the goal is to bulken up the stool. So you can use psyllium, Metamucil, Benefiber, fiber supplements in order to bulk in the stool. And the goal is to have a formed stool, which can be removed with disimpaction. So diving more into an upper motor bowel program, so it should be done after a meal, and this is to take advantage of the gastrocolic reflex that I had mentioned earlier, which naturally is the reflex where it helps you to have a bowel movement or stimulates you to have a bowel movement shortly after eating. And the goal is to have a soft formed stool, so you can do Colace 3 times a day with meals as a stool softener, and then give Senna about 6 hours before the suppository. And so if a patient is going to be on a program where they want to have a bowel movement at night, and that's when you give the suppository, you give the Senna around lunchtime. And then if they're on a morning program, you would give the Senna around midnight or before they go to bed, and the suppository would be given in the morning. And then you would give a bisacoidal suppository followed by digital stimulation. And you may need to, depending on the individual, you may need to perform digital stimulation several times to fully clear the bowels. And the goal is to have a bowel movement within 30 minutes following the suppository and digital stimulation. And then if the patient's lying on the ground, the patient should be lying on their left side in order to kind of take advantage of gravity, and your colon and your rectum ends in the left side anatomically. And then it should be done at the same time every day in order to stay on a routine or schedule. And then the lower motor bowel program. So here we're trying to bulken up the stool, and so you should use fiber supplements, psyllium, metafiber, metamucil are common ones used. And the plan is for digital evacuation of solid form stool. And you may need to perform this multiple times a day, 2 to, up to 4 times daily, depending on each person. And for this, if they're able to, it helps if they're sitting up to take advantage of gravity. And then if they're lying down, the same applies for the lower motor bowel program as well. They should be lying on their left-hand side to take advantage of gravity and where the colon is anatomically, which is on the left side, or that's where it ends. And then similarly to the upper motor bowel program, it should be done at the same time in order to stay on a schedule or routine. And then I briefly wanted to discuss bowel medications that are commonly used for our patients and are part of the bowel program. And so bulking agents, which we mentioned, so psyllium, metamucil, benefiber, Citracil, these are common ones used. And these bulken up the stool by increasing water absorption in the colon. The one caveat to this is you need to drink adequate water in order for these agents to work well. And then common laxatives that are used, so starting with stimulants, so senna and bisacodyl, these are both stimulant laxatives, and they work by increasing peristalsis. And then you have osmotic laxatives, which is Miralax is probably the most commonly used one. And then also lactulose also works in this fashion, where they increase water secretion into the intestines in order to facilitate a bowel movement. And then finally, a stool softener, Colace or Docusade is commonly used stool softener. And then you also have suppositories. So a suppository is defined as a pill placed in the rectum. And that's kind of a diagram of just like how it's done. It's just a pill form versus an enema, which is a liquid. And there's 2 common suppositories. Bisacodyl, which I think we most often use, stimulates the enteric neurons to cause peristalsis. And then a glycerin suppository draws water into the intestines. And then there's also other treatments for neurogenic bowel as well. Botulinum toxin injection, Botox injections. And so this would work by decreasing the contraction of the external anal sphincter. And it would help with patients that have spasticity or very tight sphincter. And then there's also neurostimulators. There's limited evidence of how well these actually work. But these work by sending electrical impulses to the sacral nerves to help with constipation. And then you can also do surgery as well as a potential option where you just have a colostomy, where the stool exits through the colostomy bag instead of through the rectum. I think this is kind of a last resort. We'd like to get them on like a regular bowel program, just with medications and digital stimulation prior to like going to something like surgery. Now, some key take-home points. So neurogenic bowel, it's the loss of normal bowel function caused by nerve injury, and it can lead to problems like constipation, having bowel accidents, abdominal pain, and it's an extremely common problem in patients with spinal cord injury, and it has a huge impact on people's daily lives and their overall quality of life. And treatment should be tailored to each individual. Patients might respond differently. And then also it might take time to figure out what works, and you may need to adjust bowel regimens, until they're on a regular schedule. And I think another important point is little things might, really get them off of their schedule. If they had something different to eat that might have upset their stomach, or if the timing was off. So I think it's really important to try to stay on this schedule as much as possible. But in the real world, that can be challenging to do sometimes. And then these are my references for this presentation. And then that is the end. Are there any questions or comments?
Hey Neil, can you hear us?
Yeah, I can hear you.
Quick question. Yeah, strong work. My question is, when would you utilize like an enema, or would you ever use that as like part of one of the bowel programs?
Yeah, I think you can. So we actually were, so one of our patients we have now, we're switching to an enema. He was on this bisacoidal suppository, and we're switching him to an enema. He's kind of been off schedule and hasn't been having like routine bowel movement as part of the bowel program. I'm actually not entirely sure like when we would ultimately like decide to put someone on an enema versus a suppository. I think just by the nature of an enema, it can probably be a little bit more messy, and so I think it would probably be better to have someone be on a regular routine with a suppository before going to an enema.
Do you know of any types of enemas that are like used more frequently in spinal cord injury?
That I'm not entirely sure of.
Yeah, so there's a product called NMEs, which is used very, very frequently. It's a mini enema, and a lot of times it's actually kind of shared with bisacoidal suppositories as a first-line agent for individuals with spinal cord injury and who are on bowel programs. They work pretty well. There's also an NMEs Plus that has a numbing agent. So if patients have some impaired sensation or neuropathic pain with bowel programs, the NMEs can be a very good option. And there's some evidence that it works, not great evidence, but there's some evidence that it works just as well as suppositories. And it doesn't have like a large volume, so it's not like you're having a big mess to clean up or anything like that. It works mostly by being a little bit of actually more of an irritant laxative, as opposed to like a high volume type laxative or suppository. So in some ways it works more similar. You could think of it working more similarly to a suppository. Do you know anything about, have you ever heard of a magic bullet suppository?
I think I have actually. Because Dr. Distel, when I was over at Pensy, he like briefly I think was going over that. I don't recall too much about that though.
Yeah, so it's PEG based, so it's water soluble as opposed to normal bisacoidal suppositories, which are like oil based. And so the magic bullet usually has a more of a quicker onset of action. So patients who have like a delayed bowel movement after a suppository, that could be a really good option for. And in other places that have them available, we use them pretty frequently. Sean, you had a question?
Yeah, the question is about Botox, but where does the Fleet's enema come into that? Is that the other name for the enemies that you were saying? The Fleet's enema?
Fleet is a different type of enema, kind of than an NMEs. NMEs are docostate based. So Fleets are sodium phosphate based. Actually, and they can actually, it's a brand, so it can also be other things as well. The one that we have here is sodium phosphate based, and it's more of a high volume type enema.
High volume, yeah, okay. For Botox, how would you give that injection? How is that given? Is that like right to the rectum?
So I believe because that is the spastic like muscle that you're trying to relax, and so yeah, it's my understanding that that's how it would be given in order to relax the spasticity of the rectum.
More to the anal sphincter.
Yeah, the sphincter.
Yeah.
That's not, I don't think used too commonly though.
Right. Anyway, nice lecture, Neil. Good job.
Yeah, excellent job.
Thanks,
Any
Sean.
other questions? Well, that was great. Thanks so much, Neil. Really appreciate that. And if anybody has any like tricky bowel situations while you're on service, definitely see Neil because he'll be able to kind of help you troubleshoot and work through it. So thank you guys so much. And as always, all of the lectures except for Tejas's, which for some reason wouldn't upload, are available on the YouTube channel. So thank you guys.
Thank you.
All right. Thank you. Take care.